So hello, this is Ed from Podmedics, and welcome to this podcast on antibiotics. Antibiotics is one of the most frequently requested topics on the site, and to be honest, it's a bit bad that we haven't done a podcast on it until now. So this podcast is going to be a little bit different. It's going to be a little bit more informal than our usual ones. It's also going to be a notes-based podcast. So essentially what I'm actually doing is I'm going through a set of notes that I made 4 years ago for my final examinations, and I'm going to talk you through the salient points, all about what you need to know about antibiotics as a medical student and as a junior doctor. So I think the first thing to say, and this has particularly come to light in the last 10 years and has really changed the way that antibiotics are taught at university, is that a lot of hospitals have their own protocols for using antibiotics, and in some ways I've come across students who have therefore thought that actually they don't need to know anything about antibiotics because they would just check the guidelines. And while it is certainly correct that before prescribing any antibiotics in a hospital setting you should check what your local hospital guidelines are, you do need to know about the basic classes of antibiotics, how they work, where they're commonly used, and very importantly their adverse profiles. So that's what we're going to be doing in this podcast. So here are all the notes that we're going to go through. There's quite a lot, so let's get started. Okay, so the first thing is, let's talk about classification of antibiotics by what they actually do. Now, antibiotics primarily have three broad actions. They can inhibit cell wall synthesis, they can inhibit protein synthesis, and they can inhibit nucleic acid synthesis. So when we're talking about inhibiting cell wall synthesis, we've got the drugs such as the beta-lactams. These are things like penicillin and its derivatives such as the cephalosporins. We've got Glyco Peptides, which are more hardcore versions of penicillin such as vancomycin, teicoplanin. We've got the Carbapenems, which such as imipenem. And we've got monobactams such as aztreonam. Then we've got the group of drugs that inhibit protein synthesis, and likewise these are fairly common drugs, Amino Glycosides such as Gentamicin, the tetracyclines, that's tetracycline, doxycycline, oxytetracycline, that kind of thing. We've got Macrolides, Erythromycin and Clarithromycin. Note those are very important drugs for patients who are allergic to penicillins. We've also got some other ones such as chloramphenicol, very commonly used in ocular preparations, fusidic acid as well. Our final group are those that inhibit nucleic acid synthesis. So in this group I include the Quinolones, that's ciprofloxacin, ofloxacin, and then what I've broadly termed as others, such as Metronidazole, trimethoprim, Rifampicin, and the group of drugs called the sulfonamides. Okay, so let's start at the top and let's look at penicillins. So penicillin's very common, the first real antibiotics, and the first thing to say is that these are really useful against gram-positive, particularly some of the first generation penicillins. All the penicillins since then have basically added on additional gram-negative cover to the already good positive cover. So the four major types that you guys need to know about are the very basic penicillins, which are active and are effective against pneumococcus, streptococcus, and meningitis. And basically here we have an oral one and an IV one. So the IV one is the traditional benzyl penicillin, sometimes referred to as penicillin G. And then we have an oral version, which is phenoxymethylpenicillin or penicillin V. And this is given orally, but generally it's got quite poor bioavailability, but it is still used. We've then got broad-spectrum penicillins. Now these have gram-positive cover, but they also cover more gram-negatives, for example E. coli and Haemophilus. And the classical one here is amoxicillin, and you'll certainly see that prescribed a lot. We then have other ones, such as the beta-lactamase-resistant penicillins, and the two classic ones here are flucloxacillin, which introduces some staphylococcal cover to the penicillins, and augmentin, otherwise known as coamoxiclav. Once again, a very widely used antibiotic. And then we've got some more hardcore penicillins, the anti-pseudomonal penicillins, such as tazocin. Okay, so this is our first interaction with my adverse profile table, which I like to use when I'm learning about all drugs. And as you can see, it's got 3 columns. It's got contraindications, it's got important side effects, and it's got interactions. So let's start with the middle column, because this is the one that you'll most commonly need to know about. And with penicillins, a lot of people do have allergic reactions to penicillins, and these can be in a very basic form, such as a rash, or in a more severe form, such as a severe anaphylactic reaction. Some people also get some nausea and vomiting with penicillins. Now, if we extend that, as you can see, the contraindication should be fairly obvious, and this is the case pretty much for all drugs, that major contraindication to a drug is hypersensitivity. In terms of interactions, although to be honest this isn't such an issue now as it used to be with recent studies, is that the penicillins can reduce the efficacy of the combined oral contraceptive. Okay, so let's now talk about the next group, which are the cephalosporins. So there are 3 generations of these, and the thing to remember is that as you move through the generations, then the gram-negative activity becomes greater. So first of all, let's talk about the first generation, which are generally fairly weak drugs. The one you need to know here is one called Kefir Lexan, and is orally active. And this is used in a couple of situations. It's a drug that's often used, not in URTIs as the note says here, but in urinary tract infections, or UTIs. And it is certainly in some centres a first choice antibiotic for that. It's also sometimes used in patients who have refractory cystitis, and they will often take it on at a low dose but on a continual basis to prevent urinary tract infections. So the second generation, we've got cefuroxime, which essentially has the same indications as amoxicillin. And the third generation, these are the ones that tend to be used IV, and they're cefotaxime, ceftazidime, and ceftriaxone. Now, I wouldn't worry so much about the indications for these, just know that they exist and that they're third generation cephalosporins. Okay, in terms of adverse reactions, the first thing to talk about is the Clostridium Difficile. Now, this is one of the major reasons that these antibiotics, the cephalosporins, are less used in a hospital setting and indeed in the community than they once were, because they do predispose the patient quite heavily to C. diff. Other side effects that you may want to know about if you're keener include bleeding and thrombophlebitis if you're giving the drug IV. In terms of contraindications, yes, hypersensitivity. Patients can be hypersensitive to cephalosporins, but often you're going to come across a situation where you want to prescribe a cephalosporin and you know that the patient is penicillin allergic. And the figure you need to know here is that roughly 10% of those people who are allergic to penicillin will also be allergic to cephalosporins. Okay, so let's move on now to the Glyco Peptides. This includes drugs such as vancomycin, which is commonly used for MRSA and C. diff, and teicoplanin, which is one of our more hardcore antibiotics. Now, generally, the Glyco Peptides are active against aerobic and anaerobic gram-positives. In terms of important side effects, the most important ones here, I'd say, would be ototoxicity and nephrotoxicity. But they also have this problem with thrombophlebitis. But ototoxicity, nephrotoxicity, those are the ones that you really need to know about. Contraindications aren't many important ones, but obviously if the patient's allergic to glycopeptides, you shouldn't prescribe them. In terms of interactions, there's an increased risk of the ototoxic effects if they're given with loop diuretics. And you should also be aware of the increased risk of nephrotoxicity with these drugs when they're given with cyclosporin and the amino glycosides. Okay, so now carbapenems. Now these are drugs such as imipenem and meropenem. They're good agents. They have a wide, broad spectrum action against both gram-positive and gram-negative. And for this reason, these drugs are often used in a nosocomial type of infection. Most important side effects are nausea and vomiting with these drugs. Okay, now the amino glycosides. These include drugs such as gentamicin, which can be used topically, say in ear infections, and also can be given IV, and drugs such as streptomycin, which is one of the agents we use for resistant TB. In terms of mechanism of action, these drugs broadly work by inhibiting protein synthesis through binding to the 30S part of the ribosome. They are generally inactive orally, they are inactive orally, and importantly with these drugs they often require TDM, therapeutic drug monitoring. And I said here you can measure 1 hour post-administration with the blood test, but there are various regimes here, particularly with gentamicin. Just like before, the important side effects here are nephrotoxicity. This is particularly important with gentamicin. So all patients who are on IV gentamicin should have their renal function checked before starting the drug, and also checked to make sure there are not any disadvantageous effects occurring. Also, you can get ototoxicity as well. In terms of contraindications, these drugs are contraindicated in pregnancy and also in myasthenia gravis. For interactions, we've got loop diuretics and cyclosporins potentially increasing the nephrotoxic effects as well. And also we find that these drugs antagonize any anticholinesterases that the patient is on, and this is the reason we don't really use them in myasthenia gravis. Okay, now let's look at the tetracyclines. The most common situation that you're going to come across tetracyclines being used in a hospital setting are in the treatment of acne with, say, oxytetracycline, and also in the treatment of some sexually transmitted disease such as chlamydia can be effectively treated with doxycycline. Generally, they're relatively broad spectrum, and particularly they are effective against intracellular organisms such as chlamydia. In terms of important side effects, the one you really need to know about here are the teeth and teeth discoloration that can occur with these drugs, and for this reason we don't use them in young patients where bones and teeth are still developing. So traditionally it's said do not use them in anyone less than 12 years of age. An important interaction with these drugs is with anything containing calcium, so particularly milk can adversely affect the absorption, iron tablets, and also magnesium that's commonly found in antacids. In terms of contraindications, and this is really a relative contraindication, you need to be careful in patients who have renal impairment giving these drugs. Okay, so now macrolides. Okay, so the most common macrolides I'd say are erythromycin and clarithromycin, with clarithromycin being a little bit more potent than erythromycin. Erythromycin, to place it in the context of medicine, is particularly used in the context of the respiratory system. For example, in exacerbations of COPD or to cover the atypicals in pneumonia. It's also a drug that you will often first think of when you're thinking of a penicillin, but the patient is penicillin allergic. It's important to note that these drugs do not cross the blood-brain barrier, so they wouldn't be useful, for example, and so useful in things like meningitis. Okay, in terms of important side effects, by far the most common thing with these is nausea and vomiting. Patients often feel nauseous and can vomit, and you need to advise patients of this before prescribing them. Occasionally, patients can also get jaundice on it, so raised bilirubin, and this is due to cholestasis. So beware of this in your patients when you're doing LFTs, having started antibiotics. In terms of the important interactions, the macrolides generally are a group of drugs that are CP450 inhibitors, and that's important to remember. There are a couple of great mnemonics for remembering the inhibitors, and also they can reduce the effectiveness of statins as well. Okay, now the quinolones. Now by quinolones I mean ciprofloxacin and ofloxacin. These drugs are effective against many gram-positive and gram-negative, and they're particularly used in a couple of conditions. They're used commonly in bowel infections, for Pseudomonas, infections in patients with cystic fibrosis, and they're also used in the context of sexually transmitted infections such as gonorrhea. Once again, like many antibiotics, the quinolones have a side effect of causing GI disturbance, nausea, vomiting, occasionally diarrhea, and they can also cause this rather bizarre condition of tendon damage as well, and occasionally you'll get tendon ruptures in patients who are on quinolones. They're CP450 inhibitors as well. Okay, metronidazole. Metronidazole is a drug you'll see used a lot in the hospital and community-based setting, and the major thing with metronidazole, and the thing you should first think of, is anaerobes. Okay, but also they are quite active against protozoal infections as well, and this is the reason they're used in Giardia and Trichomonas infections. If used for a long time, they also require monitoring. Important side effects for this. So once again, we've got GI disturbance, and this is particularly the case with metronidazole. Metronidazole can make you feel really grotty, really nauseous, and can cause vomiting. So for this reason, if you were a doctor prescribing, say, IV metronidazole in a hospital setting, I would recommend adding some antiemetics, perhaps to the as required side of the drug chart. You also need to advise patients that they may get an anti-abuse type reaction if they take metronidazole with alcohol. And this is really important to tell patients about, because if they drink alcohol while they're on metronidazole, they'll feel really, really bad. In terms of interactions, metronidazole has been shown to increase phenytoin levels, and it can also increase warfarin levels as well. Okay, so let's move on now to talk about some of the anti-tuberculous drugs. Now, I'm sure as you know, there are 4 of these, and each of them has their own particular indication and also their own particular set of problems. So this is a really important table for you to learn for your exams. So the drugs are rifampicin, isoniazid, pyrazinamide, or ethambutol. And a couple of people, well, a lot of people I should say, like to remember this using the mnemonic RIPE. So, in terms of indications, all of these drugs are used in the treatment of tuberculosis. But importantly, rifampicin also is used for close contacts of anybody with meningitis, something we call contact prophylaxis. In terms of problems, let's spend a bit more time talking about this. So rifampicin can cause deranged LFTs. It can cause orange secretions. This is a particular favourite for exam questions. And it's one of the drugs that's a CP450 inducer as well. Isoniazid is particularly associated with peripheral neuropathy, and you can treat that peripheral neuropathy with pyridoxine. Once again, favourite for exam questions. Pyrazinamide is associated with hepatocellular toxicity, and ethambutol is associated with retrobulbar neuritis. Okay, so now, in order to put this into a bit of context, let's go through a table of some common types of infection and talk about some regimes that may be used in that setting. So one of the most common reasons that you'll use antibiotics in the hospital setting is for the treatment of community-acquired and hospital-acquired pneumonias. Now, community-acquired pneumonias tend to be strep-based or Haemophilus-based, or they could be atypicals, Mycoplasma, and rarely Legionella, Chlamydia, PCP, that kind of thing. Most commonly, in patients we see in the community who have mild pneumonia, and remember pneumonia can be scored using this CURB-65 score, we just treat them with a mix of amoxicillin and erythromycin. So amoxicillin to cover the typicals such as strep, and erythromycin to cover the atypicals. If a patient was coming into hospital and was requiring IV therapy perhaps because they had a severe pneumonia, you might consider using some different antibiotics such as coamoxiclav or augmentin, or you may consider using one of the later generation cephalosporins such as cefuroxime. And then again, you might want to consider erythromycin if you're suspecting an atypical infection. Specifically in terms of atypicals, clarithromycin can be used. This is particularly useful as it's more potent. And for PCP, which is one of the opportunistic infections associated with HIV, we use cotrimoxazole. That's another favourite for the exams. In terms of hospital-acquired, these infections tend to be more serious, and they tend to be sort of more selected gram-positives and also quite a few gram-negatives as well. So for this reason, we need a much broader coverage that the penicillins may not offer. So we might consider using an amino glycoside intravenously, such as gentamicin, together with, say, a third generation cephalosporin. But this is one of the situations where hospitals will have their own very specific guidance about this kind of thing. For aspiration pneumonias, don't worry so much about the choice of penicillin. You'd want to choose something fairly bulky, such as a cephalosporin or perhaps a broad-spectrum penicillin. But the important thing is, because we're dealing with anaerobes in aspiration pneumonias, we need to cover with metronidazole. So that's an important point to remember. In terms of TB, you need to remember RIPE, basically. Try and remember each set of adverse effects that you get with each of those antibiotics and what the specific therapy for that is. Moving on to meningitis. So meningitis, this is an important situation where you need to know the emergency treatment, and it's common in the community, if you suspect meningitis, to give immediate antibiotics because it's very important to start therapy early. And this is done using a bolus dose, 1.2 grams, either IV or IM, of benzyl penicillin. Inside the hospital, once again, you'll go via protocols, but you're going to want to use fairly heavy antibiotics to treat meningitis. Notice also here that I've mentioned again that close contacts of meningitis are often given a couple of days of rifampicin or a single dose of Cipro to reduce their risk of developing full-blown meningitis. Okay, and now let's move on to just some smaller situations. Septicemia, so once again, hospitals are going to have the very specific guidance. The important thing with septicemia, if it's suspected, is that you get the blood cultures in early while the patient is febrile, and that you preferably do that before starting any antibiotics. Neutropenic sepsis, once again, you need to get blood cultures early and you need to start heavy-duty antibiotics. UTIs, I mentioned briefly before, but important, there are a couple of options for UTIs. So one of them was Kefir Lexan, but more commonly we see UTIs being treated nowadays with trimethoprim. For MRSA infection, we often see vancomycin being used, as this can be used orally. C. diff, often following cephalosporin treatment, can be treated with metronidazole and vancomycin. You will see a lot of patients who come into hospital with cellulitis, and the important thing with cellulitis is that you cover both staph and strep. So if you remember when we talked about the penicillins earlier, you would cover your strep using benzyl penicillin and you'd cover your staph using flucloxacillin. And the last one is this pre-surgical group. Now, pre-surgical, this is a situation where a patient comes in, perhaps they got an acute abdomen and they're septic, and you want to start some antibiotics. And the important thing here, once again, when you're dealing with the gut usually, is to think about covering anaerobes. So you're going to want to be using a powerful, broad-spectrum penicillin together with metronidazole, which is great for the anaerobes. Okay, so that was a really quick run-through of antibiotics. You might want to go back and watch this podcast a few times. You might want to download a set of slides on this podcast as well. If you've liked this format of podcast, let me know and I'll do some more just like this. Thanks for listening.